Hello, this is Dr. Craig Thomas. Thank you for joining me today. We're going to have a course on the diagnosis and treatment of epiphora, or abnormal tearing and watering of the eye, and we'll call it Crimea River. I thought that was an interesting title for us. To get into this course, we need to review a little bit of the anatomy and physiology of the lacrimal functional unit. According to the Dry Eye Workshop report, the lacrimal functional unit maintains ocular surface homeostasis by regulating tear flow. And anybody that's heard me talk before knows that I really don't want to read slides to anybody. If I'm reading it out loud, that means it's almost like a test question. So we'll look at the slides and I'll try to talk as we go. But this, we got to have some basic information. So again, this lacrimal functional unit, we'll start with that. It consists of the cornea, the conjunctiva, the lacrimal and meibomian glands, and most importantly, it's connected by a neural network, so a bunch of nerve endings on the surface of the eye, and all these structures, the cornea, the conjunctiva, the glands, and these neural network and the nerve endings includes the lacrimal drainage system. And the neural response is initiated by activation of sensory nerve endings on the cornea and the conjunctiva. If you can visualize it, the neural feedback loop looks like this, where you have a constant, almost a biofeedback rhythm, so to speak, where the nerves on the ocular surface figure out what's happening on the ocular surface and selectively send impulses to the glands to either increase or decrease tear production to maintain this homeostasis. So here's a visual of our neural feedback loop and how all the structures are interconnected by this neural network. The lacrimal functional unit, again, consists of glands that produce the tears, but also the structures, the appendages, ducts, and glands that drain the tears away from the surface of the eye. And so you have what's called the outflow of tears, which is accomplished by this lacrimal drainage system. You see a representation of it here. We've all seen this image in optometry school. The margin, the punctum, the canaliculus, lacrimal sac, lacrimal duct, the tears draining down through this system. So again, just a refresher on the anatomy and a little bit of the physiology of the lacrimal drainage system and the lacrimal functional unit. So let's talk about normal tear film drainage. So you always have to know what's normal before you can determine what's abnormal. So when we're examining our patients, a refresher again on what the normal tear film drainage should be. Remember, the tears are flowing along the upper and lower margins of the lids, and as the lids kind of squeeze together, and it's an undulating flow. It's not an up and down thing. So with each blink, the orbicularis muscle squeezes the eyelids together, squeezes the fluid into the puncta. You've got some capillary action kind of sucking the fluid down into the duct. Again, you guys can see it on the slide. But remember, we all learned this in optometry school. They haven't changed the basic science of tear film drainage in the 30 years since I got out of school. So just a review again of how it's supposed to be when the eyelids are normal, when the tear film drainage is normal, when the tear secretion is normal, and you have a regulated homeostasis where the exact amount of tear film that's coming in equals the amount of tear film that's going out, and you don't have any abnormal watering of the eye. So kind of the same going in, same going out. When you have abnormal tearing is defined as epiphora, and epiphora is a specific type of tearing. So epiphora refers to abnormal tearing or watering due to an obstruction in the lacrimal outflow pathway. That's almost a test question again. It refers to obstruction. So when you say epiphora, and this is something I really didn't know up until I started preparing for the course and doing a little bit of research. I always used epiphora, at least I did, to just describe watering of the eye, abnormal watering or tearing of the eye. It didn't really matter what the source of it was or the etiology of the cause. If the eye was watering abnormally, I used to just refer to it as epiphora. What we'll see in a moment is that's really not true anymore. So epiphora is when you have abnormal tearing or watering due to some obstruction, and it can be an anatomical obstruction or it can be a functional pathway obstruction. And you see that the two different types are two different classifications of obstruction. So anatomical is when you have some kind of a blockage or stenosis of one of the orifices, the punctal orifice. A functional obstruction may be because the eyelid doesn't hook up to the globe right. You see the examples there: punctal ectropion, eyelid laxity, malposition. So these things can also cause abnormal tearing or watering secondary to obstruction. Now, The second thing, abnormal tearing or watering, is called hyperlacrimation. Now, it's also called pseudoepiphora, but the more accurate term, and the term I want to use, is hyperlacrimation. So you've got epiphora, which is due to an obstruction, and then you've got hyperlacrimation, which refers to abnormal tearing or watering due to reflex irritation of the corneal and conjunctival surface. And you see all of the various conditions that can cause this hyperlacrimation. Dry eye blepharitis, any kind of foreign body or abrasion on the surface of the eye, an allergic response, environmental factors like a cold or wind, sleep deprivation. So there's lots and lots of things that can cause hyperlacrimation, but hyperlacrimation is not epiphora. Epiphora is when you have an obstruction in the lacrimal outflow pathway, either an anatomical one or a functional one. And that's what we're going to talk about today. We're going to talk about either anatomical lacrimal pathway obstructions or functional lacrimal pathway obstructions. All of these things that cause hyperlacrimation are really beyond the scope of this 1-hour course. And most of us attend courses all throughout the year where they talk about all of these various conditions. I mean, we've all been to a dozen dry eye courses and courses on blepharitis. There's all sorts of articles in every journal that we read now about blepharitis. Ocular allergy has been beaten to death in every journal for the past 10 years. They always say if you want to be a medically oriented optometrist, start treating ocular allergy. It's almost nonsense. We're going to talk about some other stuff today. We're going to talk about this epiphora. That's what we're going to talk about. Okay, so we're going to keep going. Evaluation of the watering eye. So what's the goal of the exam? How do you examine someone that has abnormal tearing or watering of the eye? And what's the goal of the exam? What are you looking for? So the first thing, of course, is you're going to get the history, the exam. You're going to do all the things you see there on the bullets. And the primary goal is to differentiate epiphora from hyperlacrimation. That's the main goal of the exam, because you can't treat anything until you know what you're dealing with. So you got to see, are you dealing with epiphora or are you dealing with hyperlacrimation? Then if the diagnosis is epiphora, which is what we're talking about on this course, then the second goal is to differentiate anatomical causes from functional causes and find the site of the obstruction so you could try to fix something. So those are your goals in evaluating the watering eye: differentiating epiphora from hyperlacrimation, and then finding if it, classifying it between anatomical and functional, and then finding the site of the obstruction, kind of part 1, part 2, part 3. So this is how you examine a patient that has abnormal tearing or watering of the eye, and the things that you're looking for and what you're trying to do. So the first thing is you're going to do an eyelid evaluation. You're going to evaluate the eyelid for the proper eyelid globe congruity. Remember our anatomy, that the eyelid should smoothly oppose the globe. Abnormal findings would include ectropion or entropion or some kind of pseudotrichiasis if the eyelid was turning in a little bit. Secondly, you're going to evaluate the eyelid for proper punctal apposition. The lower punctus should not be visible. So when you're just looking at the person's eye, the lower punctus should not be visible. You should have to physically pull the eyelid down and really expose the puncta to see it. If you don't have to do that, then there's probably something wrong with the position of the puncta. And when the eyelids close, the upper and lower puncta should come together and kind of kiss each other. And if they don't, then something's wrong, and that may be the cause of the person's watering eye. Third, you should evaluate the eyelid for the dynamics of closure, the dynamics of eyelid closure. You do that by looking at the amount of eyelid tension or the amount of lower eyelid laxity. And that's characterized by what's called punctal eversion. And I've got a picture of that coming up, where when you close the eyes, one eyelid kind of overrides the other. A second characteristic of lower eyelid laxity is when you pull the eyelid away from the globe, it snaps back slowly. And again, we'll have some images of that. So the eyelid evaluation is one of the most important parts of any kind of evaluation for a person with epiphora. And here's some images of the eyelid eversion, punctal eversion. So you see kind of picture 1, picture 2, picture 3, picture 4. You see when the eyelids are closing. This is an older lady. This lady's about almost 90 years old. And this is a common problem when people get that old. So you see the eyelid is lost its tension, it's too loose. It's kind of pulling away from the globe. So you have abnormal eyelid globe congruity here. So this is a functional pathway obstruction. This is why this patient's eye is watering. So when it blinks, when the person blinks, you see here at the very bottom, the puncta is everting out, is turning out. And so you can't get any of the normal drainage function that's supposed to occur because the eyelid is in poor congruity with the globe. It won't work like that. So here's an example of what that would look like as you're watching the patient blink, kind of, 1, 2, 3, 4. The second goal, if a person has epiphora, and by definition, again, we're talking about epiphora. So the second goal is to differentiate the anatomical causes from functional. You can do it, and patients where you're working on that have Medicare insurance and you're doing diagnostic testing and probing and flushes and dilations and irrigations. Medicare is pretty specific about who you would do this test on, and you can't just do stuff to people just because their eyes are watering. You have to do some non-invasive testing to diagnose punctal and post-punctal obstructions before you just start going at people with procedures. However, procedures are extremely helpful and extremely important in evaluation of the watering eye. And you've got multiple peer-reviewed sources that say dilation of the lacrimal punctum allows for all sorts of benefits. You can assess the functional or mechanical stenosis. You can kind of figure out where the site of the obstruction is. So a lot of benefits to doing procedures. And again, we'll show some images of that as we go quickly. So again, more things about how to evaluate the watering eye. Here's an example of what we're talking about where you're looking at a functional obstruction and specifically failure of the lacrimal pump. And I put these images here. Again, this is an older patient, probably, I'm trying to remember, maybe 78 years old, 75 years old. You've got what appears to be a normal eyelid apposition to the globe. So if you look at the first image right here, this is just the patient at rest. Everything looks fine. You can't see the punctum, so they kind of pass the first test. The eyelid is smooth right here against the globe. Everything looks fine. Put some fluorescein in, and you can see a fairly heavy tear meniscus. To me, that's abnormal. And over here in the canthus, you've got a collection of tear film that's showing up with the fluorescein dye. And again, that's abnormally heavy to me. And this person is complaining of her eye watering. So again, the patient came in with a chief complaint of my eye running water, and so I'm beginning my evaluation, and I'm starting with an eyelid evaluation, trying to see if there's some functional thing before I see if there's an anatomical thing. And again, so you can see what it looks like. Now here would be an image after I put the dye in and after the person is blinking. And you can see a collection of fluid. We've all seen this before. I've been practicing a long time, over 30 years, and I'd have to admit that there were times where I would see this earlier in my career and not quite know what I was looking at. I didn't quite understand the clinical significance of it. Now I do, of course, and I want to share that information so we don't have to take so long to everybody to learn this stuff. But I used to look at this and not quite know what it meant. I didn't know that it meant a failure of the lacrimal pump mechanism when I would see tears spill over every time the person blinked. So I mean, I'm looking at this now and I'm like, oh, I know exactly what's going on. Here would be a video of that same person. Now watch this, watch this. So see the person blinking. The tears are not going down into the punctum and into the lacrimal drainage system. They're balling up and running down the side of the patient's face. Okay, so you have a failure of the lacrimal pump here, even though the eyelid looks normal. And here's a different image. Now see, same patient, and I'm pulling the eyelid away from the globe. I'm grabbing the middle of the eyelid right here with my fingertips. I'm just grabbing it gently, pulling it away from the globe, and then watching it snap back. Look how slow that is. Look how slow. Watch again. I'm going to pull it away, and see, that's too slow. So here, as you evaluate the dynamics of eyelid closure, this is a clinical sign of eyelid laxity, lower eyelid laxity, where you pull the eyelid away from the globe and it doesn't snap back real fast. Now let's kind of pivot. We were talking about functional lacrimal pathway obstructions. Now let's talk about anatomical lacrimal pathway obstructions, because the first thing, I hate to say it, but all this functional stuff, with the eyelid laxity, we've got the failure of the lacrimal pump. You can see what it looks like. Okay, all of this stuff here, when you've got functional pathway obstructions, that's real hard for an optometrist to fix most of the time. Most of the time, these are surgical things where you got to tighten the lid up. Most of us can't do that kind of stuff. I mean, you still need to know what's wrong with your patient, but I really like concentrating on stuff where I can actually help my patient beyond sending them to someplace else. I like to concentrate on things where I can help my patient while they're sitting in my chair. So let's pivot and talk about the things where we can make a bigger difference in helping our patients, and that's these anatomical lacrimal pathway obstructions. The first one and the most common one I want to discuss is punctal stenosis. So here's an image of the lower puncta. You see that the punctal orifice is essentially closed. It's going to be very difficult for any kind of tear film to drain into the lacrimal drainage system through a puncta that is essentially closed up. That makes it pretty tough. One of the good parts about this is that it may be easy to fix, and it may be as simple as putting in a drop of proparacaine and inserting a punctal dilator into the punctum and kind of just twisting it around and opening the orifice up, and it may stay open just like that. It just may need a little bit of help getting open. And a lot of times after I do this procedure, you see the bottom here, me just simply dilating, kind of opening up the punctal orifice. Then I put the patient on steroid drops, some Lotamax gel or Lotamax suspension, even Pred Forte, for 2 or 3 weeks. Try to keep that thing open, and I've had a lot of success with that through the years. So the punctal stenosis. It seems simple. To me, it is relatively simple. It's not a rare thing. I see it on a pretty regular basis throughout the day, or I guess throughout the week. I'll go days without seeing one, but I have a patient base that has a lot of elderly patients, and this is not an uncommon presentation for me. So here will be the first example. Secondly, and any of you guys that have followed my posts, the past 3 or 4 months on OD Wire, know that I've been talking about patients getting canaliculitis. I've actually, since my last thread on canaliculitis a month or so ago, I just had my 6th patient this year with canaliculitis, and I'm going to talk about him in a minute. So I'm kind of on this canaliculitis kick right now, and I think it's a condition that has been misdiagnosed and underdiagnosed. So I want to try to increase awareness of it because I can't be the only optometrist in the country seeing patients with canaliculitis. So you've got the typical patient being a postmenopausal woman who presents with some of the or all of the following symptoms. The first, and the reason we're talking about it, is epiphora. The most common symptom of a patient with canaliculitis is epiphora, watering of the eye, abnormal tearing or watering of the eye. That's the most common symptom. So whenever I see a patient where that's the chief complaint, in my mind now I want to make sure the person doesn't have canaliculitis. You're going to usually have, almost always, some of these other clinical signs and symptoms. And again, I'm not going to read the slides. You can see that stuff there. One of my first patients years ago, and fortunately I have had a good image of it, was this gentleman here that presented with almost all of these symptoms. And you see the scaly, rough appearance of the lower eyelid here. That's real common in primary canaliculitis. One of the most common things, probably, I'd say the literature says 60 to 70% of the patients that have canaliculitis have a clinical sign known as punctal regurgitation, where if you gently kind of express the canaliculus and the whole nasolacrimal system, if you start kind of on the side of the nose and kind of gently push up, you'll see an expression of mucopurulent fluid. It can vary in consistency. It could be a real light like you just saw here. Let's look at that again. So it could be real light and kind of milky-ish clear here, and you'll see some others as we go. So, but some type of discharge that's not clear. It's not water. It's not clear tear film. There's some kind of bacterial discharge associated with this. I mean, it has some kind of opacity to it. So this is an example of punctal regurgitation, a finding that you'll see 60 to 70% of the time in canaliculitis. And every patient that I've had has had some type of punctal regurgitation. That was the classic sign to me. What you have on most cases of canaliculitis are canalicular obstructions, and you can divide these into the location where the site of the obstruction. So it could be a proximal obstruction, a mid obstruction, distal. And again, you can see the examples and definitions of them, where the proximal obstructions are right at the beginning, kind of right at the punctal orifice, mid-canalicular, 6 to 8 millimeters down from the puncta, and distal defects, which are 8 millimeters or more from the puncta. And those are things that usually optometrists are not going to be messing with too much. I mean, I've done some probings in my career for sure, but it's not a common thing. Most of the obstructions we deal with are going to be right at the punctal orifice or mid-canalicular, 6 to 8 millimeters down. And those are things where we can get at them and actually do some good. Easily, where it's not going to be real uncomfortable for the patient, or you have to have an exceptionally high skill level to do the procedure. So another example of primary canaliculitis. Here you see the same type of punctal regurgitation that we saw in the video. This is a patient of mine, a 78-year-old black lady. This lady had a 2-year history of recurrent conjunctivitis, and I must admit it's almost my fault. I mean, I probably saw the lady 10 times and tried every antibiotic I could think of. I mean, it was really kind of ridiculous that I couldn't get rid of this lady's conjunctivitis, and it never popped in my head that she might have canaliculitis. She never had, until this visit, until the 15th visit, she never had any punctal regurgitation. And I certainly had manually expressed the system and poked and prodded her, and I'd probably even flushed her 2 or 3 times, but she had never presented like this. And this was the way she came in probably 4 or 5 months ago. I think I actually posted this lady up on OD Wire when she came in. So here you see the punctal regurgitation, and yeah, I did, because this was a lady where we had the canaliculus that came out. So I'm pressing on the lid. You can see I'm pressing with a cotton-tipped applicator. So I've got a cotton-tipped applicator on the inside of the eyelid, and either my fingertip or another cotton-tip applicator here on the outside, squeezing them together gently and kind of just rolling it up bit by bit. And you can see this thing getting ready to come out of her puncta. And it's a concretion, in the general sense. When I finally got the whole thing out, this is what it looked like on my fingertip. And I did post this up on OD Wire. And so this is a canaliculith. It's composed of thick mucopurulent and particulate discharge, and it forms this abscess-like accumulation of debris. When you've got something like that in the canalicular system, if you try to irrigate them and flush through and see if the system is patent, you're not going to have it flush through. So this thing is going to block it. If you put them on antibiotics, what the literature says is that this thing almost collects bacteria like a sponge when it's down in there. And as long as that thing's down in there, it's almost impossible to make the infection go away with any kind of topical or systemic antibiotics. You've got to get that thing out of there, and the way to get it out is to manually express it. So patients with canaliculitis, they have to be expressed to see if there's any kind of canaliculith, a dacrylith, any kind of sulfur granule, any kind of cast, any physical obstruction in the nasolacrimal drainage system. Here's another example of primary canaliculitis, and primary canaliculitis is a canaliculitis that happens for no apparent reason. Where the patient didn't do anything to make it happen, it just happened. People ask me all the time, Dr. Thomas, how come I got this? And I tell people, hey, people get stuff. Every once in a while people get canaliculitis. It tends to be mature people. The youngest patients I've had have been in their 50s. The oldest patients have been in their 80s and 90s. So I mean, it's usually something that happens to mature people, and they'll have chronic conjunctivitis, chronic red eyes, chronic foreign body sensation, multiple treatments with multiple antibiotics, going to 2 and 3 doctors sometimes, trying to shop for a cure. Those are the clues that'll tell you the person might have canaliculitis. So this patient comes in. This one, again, I saw probably 3 or 4 months ago. So now I'm getting pretty good at recognizing, although, again, he had the mucopurulent discharge that you see right on the eyelids. So when I saw this, I was pretty suspicious, and I thought I knew what was going on as soon as the guy came in, because he came in and said his eye was bothering him. He had ocular discharge. He had this mucus that I saw here. You see this mucus collecting down here on the lower lid. So as soon as I saw it, I was pretty suspicious that that's what he had. And the way I treat it now is this. I manually express the nasolacrimal drainage system. I'll sit them in the chair and put some warm compresses on them right then, try to draw that stuff up. I'll put on my antibiotics, topical. I'll put them on systemic antibiotics. If I think it's fungal, I'll try that. But all the research and the studies show that most of the time, the bacteria that cause canaliculitis is some kind of strep or staph. So regular antibiotics will kill it most of the time. They used to think it was always a fungal thing, but the modern studies show that that's not the case. And most of the time, it's strep or staph. You always want them on some kind of steroid combined with the antibiotic. And last, and I don't want to say most importantly, but really important, is the antibiotic irrigation of the nasolacrimal drainage system. And you've got an image of me with an irrigating cannula right here. I don't want to say injecting, I'm injecting some antibiotic into the nasolacrimal drainage system through the punctal orifice there. So I've got a bunch of Bessie Vance. That's what I use most of the time. So I've got an irrigating cannula, a little small syringe. I'll fill this thing all the way up with this Bessie Vance. This is an off-label application. Please, nobody get mad at me. The standard treatment, according to the peer-reviewed journals, according to these guys right here, the standard treatment for primary canaliculitis, if you want to do an antibiotic irrigation as part of your treatment options, which is highly recommended, then you would use fortified cefalozin solution prepared at 50 milligrams per milliliter. Okay, you could do that if you want to. That's fine. That is the standard treatment. I never know when patients with canaliculitis are walking in my office. I don't have a compounding pharmacist sitting in here. I have found through my experience that this Bessie Vance approach works really good, and I don't know if it's as good as this, but it works really good. If I didn't have any Bessie Vance, I would use Tobradex ST. What you want is something sticky. You want the vehicle to be sticky like it is with the Bessie Vance and the Tobradex ST, so that when you flush it into the system, so when you put it in the cannula, kind of force it down in there into the canaliculus and down into the nasolacrimal drainage system, you don't want that stuff to the antibiotic. And if it was the Tobradex, the steroid, you don't want it to wash away, to be diluted real fast. You want a longer contact time. And these medications have that sticky vehicle where you get the longer contact time. So that's why I use Bessie Vance or Tobradex ST as opposed to the standard treatment of the fortified cefalozin. And again, in the small sampling of patients that I've done this on, I've really had good results with the condition clearing very, very quickly. So I'm a big proponent of now intracanalicular antibiotic irrigation in patients with canaliculitis and patients with chronic or recurrent conjunctivitis, in patients where I just even think they have canaliculitis. I'm doing this intracanalicular antibiotic irrigation, and it just really seems to knock stuff out real fast. I'm a big believer in that. Here's an example of doing it again. So I've filled up the syringe with antibiotic solution. You see it's kind of milky. It's kind of hard to find the puncta. There we go. Now look, see how it came out the top puncta. So the system is still blocked. Let's look at that again. So I'm putting it in, put the tip of the cannula into the puncta, gently depress, and you saw how the Bessie Vance, it just looped around and came out the top. It didn't go down into the canaliculus and down into the system like it should have. So the system is still blocked. I didn't want to probe this lady today, but if I couldn't get it clear, I would get more aggressive with the treatment options when the person came back, because you see I'm not quite finished yet, but some treatment is better than no treatment. If somehow I couldn't get it opened up, because you saw it was blocked, you could probe it, you could irrigate it, see if you could figure it out. I put them on drops. I've had some success where I do an initial intracanalicular antibiotic irrigation, and if they didn't show improvement at 48 hours, do it again. And what the literature shows is that for some patients, you may have to do that 4 or 5 times to really get rid of the infection, where you might have to irrigate them with antibiotics, have them come back in 2 days. If they're not a whole lot better, irrigate them again, have them come back in 2 days, 2 more days. If they're not a whole lot better, irrigate them again. And you have to do that 3 or 4 or 5 times to really get rid of a chronic infection that's been hanging around for 2 years. I've found that really 1 or 2 times is enough for most of my patients. I haven't done anybody more than twice. I've done a couple of guys, where I had to do them twice. But most people, if you hit it one time with that antibiotic, get it to go through, and it goes all the way through. It doesn't loop around where it regurgitates out the top puncture. It goes all the way through. That knocks it out most of the time. If somehow you couldn't get it done after trying 2 or 3 times, then you can send it to some oculoplastic surgeon. They can do that dilation of the punctum with the curettage of the canaliculus. They can do a canaliculotomy with or without stent placement. I've had probably 10, 12 patients in my career go through the drama of doing that stuff where they have tube placement and stents put in and all kind of oculoplastic surgery. It's really quite a pain, to be honest with you. And I don't make that recommendation lightly. It's almost like real surgery. It's not like having cataract surgery, some of the stuff that we do all the time where it's real easy, real quick, immediate recovery. I've seen patients where this stuff doesn't work. They've got to have 1 or 2 more procedures. It can be really difficult, and there are no guarantees. I think I've got just as good a chance as anybody at fixing the patient doing it the way I'm doing it now. And so I'm really hesitant to make that oculoplastic referral because it's almost like doing a corneal transplant referral. You may get a good result, you may not. I mean, the surgery can be real good. It's just hard to do. And it's not guaranteed results, and so you may get good results, you may not. I don't like messing with it. I'd rather try and fix my patient myself. So the treatment options that I do: medical management. It's got a higher rate of success if you can catch the patient early. That's why you've got to kind of increase your suspicion for patients with canaliculitis, because you get a much better outcome, much better results if you can attack that thing early, the first few months of the presentation, as opposed to finding someone that's been bouncing around for 6 or 12 or 18 months. No one's figured out what's going on, and then you try to have at it. If you can get the patient earlier, right at the beginning, and realize half of these are going to be your own patients. I mean, it's not going to be somebody else's patient. It's going to be your own patient, where the patient keeps coming back every 3 or 4 months with the same problem. That's one of your clues. That was the clue on a couple of mine. Early intervention is a key as far as your treatment options. Your topical and systemic antibiotic, just start with almost anything. A lot of the literature says that you need to, do a culture sensitivity to really figure it out. I found several articles that said just hit them with broad spectrum drugs and you can figure it out later if it doesn't work. But you just want to start. You want to start the treatment. And last, and again, you may need to repeat the intracanalicular irrigations on more than one occasion. Those are my treatment options, and I've had good success with those. Let's keep going with this primary canaliculitis. Here's another patient. This one this was my most recent one. So this one, the 78-year-old lady comes in an emergency exam, and this one was strange because I initially thought that this was a case of secondary canaliculitis, and we'll talk about secondary canaliculitis in a moment. But when I first saw this lady on the emergency visit, I was thinking, man, this is another case. This would have been my third one in a year, where I don't think I've had 3 the previous 20 years as far as my own patients. So this would have been my third patient where it was a secondary canaliculitis, which means I caused it. And I was like, man, what's going on here? But as I sat back and reflected and thought about this one after I treated it for a while, I don't think that's what's going on. That the history doesn't support it in most of the areas. So again, we've got this 78-year-old lady who came in on an emergency exam. I had seen her 11 months earlier for 2 or 3 visits, and on that last visit 11 months earlier, I had put in a set of long-term intracanalicular collagen plugs. So I had done a trial. She had dry eyes. I'd done a trial with short-term collagen plugs. The trial was successful. She came back. I put in a set of long-term collagen plugs and dismissed her. And she was coming back on some kind of regular visit schedule. But she came in early on this emergency examination, complaining of acute pain, the pain and epiphora, watering of the eye. So the eye was watering, the eye was painful, the eye looked funny. She had severe itching and severe discharge. All of it just in the past 2 to 3 days. So that was kind of a little bit strange, and again, kind of a red herring for me in the beginning when I was trying to figure out what was going on. In the beginning, I was fixated on, I had put plugs in this patient's lower canaliculus months earlier. I told you I'd seen 6 patients with canaliculitis this year in 2015, and this was the last one. This was the 6th one. I saw her I think the week before Christmas. So I was like, man, what is going on this year? And I'm thinking, did I cause this? Am I being too aggressive with punctal occlusion? Do I need to step back a minute and look at my numbers and evaluate my outcomes and see if I'm doing the right patient selection? I've been doing punctal occlusion for 25 years. I've done really tens of thousands of the procedures. So most of the time it works real well for me, and most of the time I have no complications. So I was thinking maybe this was a person that had some type of secondary canaliculitis because of the history of the plug. So I looked at her, and you could see, just, this is the first day on the emergency exam. You could see the puncta is occluded with this mucopurulent discharge. So you've got this nasty stuff coming out of the puncta. It's all over the inner campus here, so it's everywhere. And I started kind of just gently expressing and palpating the lower lid. It was quite swollen. You see it's not real red, but it was swollen. You see the margin is real thick. I'm kind of pulling down on it and exposing it a little bit. And just with very, very gentle pressure, this kind of semi-liquid mucopurulent discharge quickly turned into this more solid, kind of cheesy looking discharge that you see coming out the puncta right here. So this is how it started. So I'm looking at, I know immediately, I'm like, okay, well, this is canaliculitis. I mean, this is a textbook presentation to me. You've got the symptom of the clinical sign that's present 60 to 70% of the time with canaliculitis, which is the punctal regurgitation. So I'm pretty sure I know what's going on. So I just wanted to start treating her. I'd figure out the other stuff later. I said, let me start treating her. So I put a couple of drops of Alkane in, trying to numb the lid up, and I grabbed the Q-tip, stuck some Alkane on it, and gently started expressing the lower canaliculus. And look at this cheesy discharge that starts to come out. It's almost like toothpaste, this thick cheese-like granular debris stuff. I mean, that's what it is. And it's composed of the mucopurulent discharge from the bacteria, the kind of particulate matter, and then all the infected debris. And that these three things together in sufficient quantity and quality produces this cheese-like discharge coming out of the puncta when you press it with a Q-tip. And I've got to tell you, in my 32-year career, I have never one time in my entire life seen stuff coming out of the puncta like this. This is pretty dramatic, I got to tell you. And as I'm sitting here looking at this, I had my assistant with me, one of my assistants, one of my technicians. So she was kind of keeping the lady's head in the slit lamp because it was slightly uncomfortable. She was whimpering a little bit as I was pressing on it because I'm sure it was uncomfortable. The eyelid was tender. You've got infection all up in here. I'm pressing on it, and I'm sure it hurt a little bit. And I just said, "Man, just work with me. I'm trying not to hurt you." And I just kept trying. I said, "If I can get all this stuff out, you'll heal up a lot quicker, and it'll be much more comfortable. Let me just try to get all this stuff out of here." So I just kept on going. I kept on going. And so here's an example of what it looked like. So I've got the Q-tip down there. So this is at the beginning. This is right at the beginning when I just started to express. You see it's still kind of semi-liquid. It's not really solid yet. See it's coming out. Okay, so that's how it started. Okay, now once I got all that semi-liquid stuff out, this more solid, cheesy looking sausage-like stuff came out. Just look at that. See, I'm just pressing gently. I don't have to push real hard. Almost just kind of rolling the Q-tip. See, just kind of, see? Look at that. Look, wow. So after enough of it would come out, I would just kind of roll it around the Q-tip, almost like a piece of spaghetti, and just get that stuff out of there. Okay? So, squeeze some of it out, get it out of there. And I would get another Q-tip, put another drop of Alkane on it or Proparacaine, and just keep squeezing. And I figured as long as it was bearable to the patient, I would just keep doing this until stuff stopped coming out. And so I just went through Q-tip after Q-tip after Q-tip, doing this exact procedure, real gentle. I wasn't in a rush. I didn't care if I had patients waiting. Just go nice and slow. Wipe it off. Kind of let her recover for a second. And here, keep going. We keep going. I went through 8 Q-tips with this patient doing this procedure. I went through 8 Q-tips where I would express this stuff out of there to where a whole bunch of it would collect right outside, and I would kind of snag it up with the Q-tip and roll it away. I went through 8 Q-tips before that stuff stopped coming out. 8 Q-tips. It was incredible. And it took about 20 minutes to get it all out. It was a nice, steady, slow procedure. I'd kind of roll it out, give her a minute, roll some more out, give her a minute. It took 20 minutes to get all this stuff out of there. It was incredible. And then I flushed her with the Bessie Vance. I did an intracanalicular antibiotic irrigation, and it did not go through as if there was still something down in there. And again, on this, just to kind of finish this one patient up real fast. So once I got all this stuff out, or thought I got it out after 20 minutes, I was like, okay, enough of this for the day. I'm gonna put her on drops. I just put her on drops. I put her on Tobradex drops. She didn't want to take any pills. She was already taking a bunch of medicine. She didn't want to take any antibiotics. I injected some of the Bessie Vance in there, put her on the drops, and I had her come back in 5 days. And she was a lot better in 5 days. And then I saw her about 2 weeks after that, and everything was fine. So it was like we got rid of it. Everything was fine. Okay. So that's how that turned out. I felt real good about that. I was able to handle it. Didn't need any kind of oculoplastic referral. I felt real good about taking care of this patient. Now, last thing we're going to talk about is secondary canaliculitis. And out of the 6 patients that I've had this year with canaliculitis, 2 of them have been of this nature, the secondary canaliculitis. Secondary meaning that it was caused by something external, and most of those times are going to be some type of silicone intubation, like if the person had oculoplastic surgery. Most of the time, the vast majority of the time, almost all the time, when we're talking about secondary canaliculitis, we're talking about a patient that has a history of punctal or intracanalicular plugs. So it's some doctor, some eye doctor, some optometrist or ophthalmologist putting in a set of plugs. You see it right here, putting in a plug, and then sometime later that plug causing the patient to have canaliculitis. So that is a secondary canaliculitis, is when the person's had a history of either silicone intubation or punctal intracanalicular plugs, and that's what's causing the problem. So those patients are going to have the same kind of symptoms where they've got ocular irritation, they've got epiphora, so we've got watering of the eyes, some kind of abnormal tearing or watering of the eyes. That's why we're talking about it, because it's the number one symptom. They'll have the purulent discharge, but they'll have the history of some procedure. So if you've got a patient coming in with ocular irritation, abnormal watering of the eye, one or both, it doesn't matter, and then some kind of purulent discharge, and they have a history of having some plugs, either by you or some other doctor, the literature supports a high index of suspicion, and I mean you should have a high index. You should be suspicious that that's what's going on, because that's probably what's going on. That's what I've seen. So secondary canaliculitis. It's a little different than primary. Really the main difference, you might have some blood-stained tears. You see a little kind of a little bit of blood right there, some redness and hardening of the eyelid. The discharge can have a little blood in it. It's real common to have granuloma formation, pyogenic granuloma. I've seen that 2 or 3 times where you've got this little knot of conjunctival tissue, kind of popping out of the punctal orifice. That's always a bad thing. You're going to put those patients on steroids to try to shrink that thing down. And again, the symptoms, just like primary canaliculitis, epiphora, the swelling, the discharge, the pain, and the history of recurrent conjunctivitis. And again, the big clue is that if you're suspicious of secondary canaliculitis, almost always for patients that are going to be in our chairs, they're going to have a history of some kind of punctal or intracanalicular plug, some kind of previous treatment for dry eye syndrome. Here's a patient, and I remember we put this up on our OD Wire earlier in the year. This was my first case of secondary canaliculitis this year, where I'd done my standard thing. This guy came in, he had dry eyes, 68-year-old black man. I tried drops on him. Drops didn't get the job done. I decided to try punctal occlusion. I always do a trial period with short-term collagen plugs, the plugs that dissolve after 10 to 14 days. The person has to come back and say, hey, my eyes feel better. He's got to come back and say that. This patient came back and said that. He came back a couple, 2, 3 weeks later and said, my eyes feel better. I said, great. Hey, let's put in a set of these plugs that'll last a while. And then I go into, my treatment option is to go into the long-term collagen plugs, the ones that last 4 to 6 months, and then I'll leave him alone for a while and see if he's okay. So I put in a set of the long-term plugs. Well, 4 days later, the guy comes back, and this is the appearance. So he comes back 4 days later, says, hey, my eye hurts, and it's running water. What's going on? And I look at him, I go, oh, something's going on. And I see this cap on the punctal orifice, so this dried up mucopurulent discharge has kind of solidified to the point where there's nothing going through there. So that's why his eye's watering, and whatever's making this infection is why his eye's hurting. So I realized what was going on because I'd just seen him 4 days earlier. So 4 days earlier, I put a plug in that lower puncta. My diagnosis was secondary canaliculitis, secondary to that plug. I don't know why it happened, because to me, if he was going to develop a complication, it would have happened when I did him the first time with the trial short-term plugs, and it didn't happen to the other eye either, which, if it was something that was just inherently wrong with him, with the plugs, if he was allergic to them or something like that, it would have been both eyes. So it was puzzling, and I still don't really have an answer. There may not be one. Why the guy developed this secondary canaliculitis in the one lower eyelid, after I'd done a trial on both eyelids, and after I did the same exact procedure on the other eyelid, that this one developed a complication. So there's really no rhyme or reason to it. I just decided, hey, let me go ahead and fix it, and because it's my patient. So I decided to fix it. So the first thing you got to do to fix it is you got to get the plug out. You aren't fixing anything until you get the plug out. So I basically grabbed a needle, kind of popped this cap open, probed around in there, and I wanted to see if I can express it out through the puncta, what would be called retrograde expression. So if I could get a Q-tip and kind of get right up in here, I just put the thing in 4 days earlier, so I knew it was still in there, because it was designed to last 4 to 6 months. If it would have moved on out the way and been dislodged, he probably wouldn't have developed the infection. So I had a high degree of suspicion that the plug was still in there. So I grabbed a Q-tip and tried to kind of just roll it out through the puncta. Once I got that stuff out the way, I could not make that happen. So I could not manually express the plug in a retrograde fashion. So then I put a couple more drops of Alkane on the guy, put a big cannula in there with a real tight seal, and flushed it through. So I irrigated the plug that was in there through the nasolacrimal drainage system, since I couldn't push it out the other way. It doesn't matter which way you do it. Well, I take that back. It's a little bit better to do the retrograde expression if you can. The retrograde expression has a safer profile, because on occasion there's a very small percentage. I mean, it's single digits kind of chance, but it does exist. On occasion, if you try to irrigate the plug down through, it may get stuck down here. It might get stuck down in the nasolacrimal duct or something. If it gets stuck down there and you can't get it out, man, now you're talking about an oculoplastic referral, and it's nothing but drama for everybody. But I've never had that happen. I'm not scared of stuff like that. If I couldn't squeeze the thing out this way, I'm going to flush it out that way. I'm going to do one or the other. I got to fix it. And I'm not going to be scared trying to fix it if there's a 2% chance of a complication. I've already got a complication. I'm already in damage control. I don't care. I'm just trying to get the thing out of there. So I'm going to try the best I can to get the thing out of there. So that's what I did. Now, the other kinds of secondary canaliculitis, well, not the other kind, but caused by a different type of plug. So you can have secondary canaliculitis caused by an intracanalicular plug, which is what you see here. You can have secondary canaliculitis caused by a punctal plug, which you see here. So here's an exposed silicone punctal plug. I've done hundreds and hundreds and hundreds of these things in my career. I mean, they work fine. I got no problem with them. They're not perfect. No plug is perfect. No procedure is perfect. On occasion, doctors that have implanted silicone punctal plugs will notice that they come loose. The plug may become unseated. It might kind of wiggle loose after a while. The person may rub their eyes a lot. It may turn in a little bit too much and rub on the globe, and maybe you picked the wrong patient to put that kind of plug in. So there's multiple reasons that even these plugs can cause secondary canaliculitis, and I've had it happen several times through the years. On one particular occasion, and the reason that I include this image, again, a lot of doctors do these. A lot of doctors have done these. This is not a rare procedure. Lots of optometrists and ophthalmologists do punctal occlusion. It's something that's done tens of thousands of times a year in this country. And so it's not rare to either see your own patients that you have plugged years later, or patients that some other optometrist or ophthalmologist have plugged, and then they end up in your office years after the procedure, and you see some plugs that were put in a year or 2 years or 3 years or 5 years ago, because you can still see the plug. So that is not a rare event to me in any kind of regular optometric practice. But so you may have a patient where either you put the plugs in or someone else put them in, and lo and behold, sometime later it's causing a problem. You would think it would be so easy to simply grab the head of the plug with a pair of forceps, the same curved jeweler's forceps that we use to put in the collagen plugs. Simply kind of wiggle them up under the head of the plug, grab the plug, and simply pull it out. And I've done that, several dozen times with, no complication, no drama. It takes 15 seconds, and you're done. However, on a couple of occasions years back, I did that, grabbed the head of the plug with some curved forceps. You kind of squeeze kind of tight to grab it and pull it up, and it's squiggly and slippery, and you squeeze a little harder to try to grab it and pull it out, and it's still slippery and sliding, and you grab a little harder to try to pull it out, and all of a sudden you snap off the head of the plug, and the thing withdraws down into the canaliculus, and you just made it worse. Well, I had that happen a couple of times. And so after that happened to me a couple of times, I'm like, maybe I need special tools to grab the head of a silicone plug and get that thing out of there. And here's an image of me using one of those special little forceps that's got little like a little jaw, little probe thing sticking out to grab the plug, little prongs right on the end of it, right there. And so I grab the plug with these now, and it kind of gets a good hold on it. You can pull it straight out. So my recommendation, and the whole moral to the story here with this slide, is don't use curved jeweler's forceps to remove these plugs, because there is a chance of snapping off the head of the plug and having the thing withdraw down into the canaliculus. And digging one of them things out is pretty tough. Your only chance now is to try to flush it through. And luckily for me and my patient, the couple of times that it happened to me, I was able to get a thick cannula and get a tight seal and flush that thing through and get it out of there. But you got to get the plug out no matter what to treat this secondary keratitis. So use the right tools and fix it. And again, now when I took this plug out, I would do my intracanalicular antibiotic irrigation. I put these little factoids here just for a few docs that might not know. For me, let's say, this plug was implanted by another eye doctor years ago, and this patient came to me with this secondary canaliculitis. If I had to take this thing out, I'm using this procedure code here, this 65885, removal of foreign body from the lacrimal passages, because as I just explained, there is risk involved in doing this. This ain't like plucking out some eyelash. So I mean, you got to, I'm not saying don't do it. I'm absolutely saying do it. I'm saying take care of your patient, but do it with the right tools. Know the risk involved, and report the service properly and get paid accordingly. And if you're going to do, if you don't want to do that, at least report the procedure if you're going to irrigate them with the antibiotics. So there's different ways to treat patients and different ways to treat this as far as reporting the service. It just kind of, to me, it depends on whether I put the plug in or somebody else put the plug in. If I put the plug in 6 months ago, I'm not going to charge Medicare or anybody else to take it out. If somebody else put the plug in and I got to fix it, okay, well then I'm using this procedure code because that's how I'm fixing it. So that's kind of some good examples to me on secondary canaliculitis. All right, everybody, we are done. This is the last slide. I hope that we've learned some things about Epiphora, remembering that real Epiphora is secondary to an obstruction, either an anatomical obstruction or a functional obstruction. The main goal of the exam is to differentiate between the two. The main goal of an exam of a patient with watering eyes is to differentiate between epiphora and hyperlacrimation. Once we get that stuff down, get our terminology down, I think we'll do a better job of diagnosing and treating our patients with epiphora, especially the ones that have anatomical obstructions where we can actively intervene and help our patients, and the ones that don't, where there's some kind of functional obstruction, at least make the correct diagnosis and let the patient decide if they want to have any kind of surgical procedures done on their eyelids to make their eyes stop running water. So at least give the patient some choices as opposed to saying, I don't really know what's going on, or giving them artificial tears, or making the incorrect diagnosis. I mean, I think now we've got much more understanding and a little bit better base knowledge of what is epiphora versus hyperlacrimation and how we're going to help our patients that come in with these symptoms. So thanks everybody for listening. I hope you learned something. I hope it was okay, and I'll see you on OD Wire.